In this video lecture, we'll look at pregnancy, concentrating primarily on the early embryonic development that takes place during pregnancy, and then talk a little in general about some of the other things that happen during the second and third trimester, and then finally end with parturition or the birthing process. So pregnancy is the events that occur from the time of fertilization until birth. That's a 38-week process. But typically, you don't measure pregnancy in 38 weeks. We measure it in 40 weeks, and that's considered to be the gestation period. That's the place or what happens from the beginning of the last period or menstrual cycle to birth. And that's a 40-week period. The only reason we do that is because it's easier to mark, or women know the first day of their last period. And so if we mark it from there and just take it 40 weeks, understanding that the first 2 weeks of the gestation period, you're not pregnant. It's hard to pinpoint ovulation and therefore the time of fertilization, so we don't measure a woman's pregnancy based on that date. It's easier just to start again with that first day of the last period. Now, the developing offspring is called a conceptus. In the first 8 weeks of development, it's referred to as an embryo. In the 9th week on through the 38th week, it's called a fetus. Now, the early stages of development goes from cleavage, which is just basic rapid mitotic divisions, but the cells don't grow in size. They're not, so the overall size of the embryo remains the same. So you can see here a 2-stage, 4-stage, and 8-cell stage, where the cells are smaller, more numerous. As it continues to divide, you end up with a morula, which is a ball of cells. Each of those cells are called blastomeres. As it continues to divide, those blastomeres arrange themselves in a hollow sphere. Inside that hollow sphere is going to be an inner cell mass. That's going to result in the embryo and the resulting baby. And the outside ring of cells here is called the trophoblast. Now, the trophoblast is going to end up becoming part of the placenta. As we go through those stages, I want you to notice as you get to the blastocyst, that zona pellucida that we see pictured here in the 2-cell, 4, 8, and morula stages disappears. So we no longer have it in the blastocyst stage. And notice too that the trophoblast cells get thinner. As the embryo is developing, it's migrating down the oviduct. So you can see here that the fertilized egg occurs more at the distal end of the oviduct. And then you get first cleavage 2-cell, 4-cell, 8-cell, and the morula. Once it enters the uterus, then it begins to form into the blastocyst, and it's the blastocyst that implants in the lining of the uterus or the endometrium, typically around day 8 or 9, can be as early as day 5, just varies by which source you're looking at. Implantation involves the blastocyst burrowing into the endometrium. The trophoblast that's on the inner cell mass size, these cells here, adhere to the endometrium and form 2 layers. The outer layer forms protrusions or cords, and you can see these cords here and here, that extend down into the endometrium and digest those uterine cells to make more room for the extending cords. The trophoblast also starts producing human chorionic gonadotropin hormone, and that's used to maintain the corpus luteum. Remember, the corpus luteum is the leftover of the follicle that releases progesterone and estrogen to help maintain the lining of the uterus. And so we need the human chorionic gonadotropin hormone to help maintain the corpus luteum, so that in turn maintains the uterine lining. The HCG also functions as an autocrine, that is a self-hormone, so it releases HCG, which in turn triggers the trophoblast to form the placenta. And also that HCG is the basis of pregnancy tests. the HCG levels increase as soon as the implantation occurs, which is around day 7. So you can actually know you're pregnant based on the levels of the presence of that HCG just 7 days into the pregnancy. Now, as the placenta is forming, the embryo continues developing. And so we'll look at the embryo development first, and that includes a stage called gastrulation, where a gastrula is formed. Gastrulation is the formation of 3 primary germ layers, and those are shown here. So here's that inner cell mass, and the blue, red, and gold represent the 3 primary germ layers, the ectoderm, mesoderm, and endoderm. The ectoderm will eventually give rise to the nervous system and skin. The endoderm gives rise mainly to the digestive tract. And then in general, the mesoderm is everything else, any other kind of tissues. And that's, again, an oversimplification probably of the 3 germ layers, but it gives you a good idea of where the destination of these 3 layers are. Now, the trophoblast plus some of the mesodermal cells that form a chorion. The chorion is the embryo side of the placenta, and you can see that here. Here's the continuing of the chorion here. And so this continues to form chorionic villi, which are basically extensions of the chorion into the endometrium. And they'll form blood vessels that penetrate within the villi and then make the connection with the maternal side of the placenta. Now, the maternal side of the placenta is called the decidua bacillus, and that you can see here as the decidua bacillus. The decidua capsularis is the side of the endometrium, or between the uterine cavity and the developing blastocyst, and that decidua capsularis is going to deteriorate away eventually. But notice too that the entire blastocyst or gastrula is completely embedded in the endometrial lining by 16 days. Also forming during this time is an amniotic membrane. You can see here in the blue is going to be the amnion, or the amniotic membrane, and that's going to swing around and completely surround the embryo like you can see here. And that's filled with amniotic fluid, and that fluid then protects the baby from being bounced around inside the uterus. Another extraembryonic membrane is going to be the yolk sac. Now, for mammals, the yolk sac's not as important. It will provide the earliest blood cells and become part of the gut and the umbilical cord, but beyond that, it has a limited purpose in mammals. Unlike birds, of course, the yolk sac's much larger. Now, the placenta, when it's fully formed, looks like this. So you can see here, first of all, here's the basal layer of the endometrium, and here's the maternal portion of the placenta here, and then the fetal portion of the placenta, or the chorion. So you'll notice too that there's no exchange of blood at all, that the maternal blood dumps into these sinuses, and then gas exchange and nutrient exchange takes place across these sinuses into the fetal blood vessels. And again, waste products are eliminated from the fetal blood and diffuses into those sinuses, and then picked up by veins and removed through the umbilical cord. What we've looked at so far is everything is taking place pretty much in this first 2 boxes here during what's called the first trimester, or the first 3 months of pregnancy. And that would be these first 2 rows here. During that time, we're going to get the first part of the development you'll see would be the formation of the spinal cord, and that's going to be starting with this primitive streak and then eventually forming the spinal cord along the length of the embryo. But we're not going to get into any more detail than that, simply because of lack of time to be able to look at all the stages of development. Keep in mind, though, that the heart actually forms or starts beating at about week 4. So the heart beats. And this is also when the neural tube that you can see here finally closes. You're not going to hear the heart or detect the heart until about 8 to 10 weeks in here in that first trimester. So it takes a little more time to get the heart big enough in order to detect it. The second trimester, which is just these 3 pictures down here, is about the fetus growing in size. Now it's going to get up to about 30 centimeters, and it's going to be very active, and most of the organs will be formed by the end of the second trimester. That's why any premature birth as early as 6 months is more likely to survive, since most of those organs have formed. We aren't relying on any other organ formation. The last trimester is all about growth in size. So the fetus grows to about 6.6 to 8.8 pounds and about 20 inches in length during that last trimester. So you increase a huge size then. Now, because most of the early embryonic development is going to be where most of the organs are formed and tissues are formed, that's the biggest danger of birth defects. Now, in the first 2 weeks, though, when you don't even have a placenta formed, the embryo isn't going to be very susceptible to any kind of environmental toxins, be it alcohol or drugs or other environmental toxins, because there's no placenta, so there's very little an exchange of anything between the embryo and the mother. If, however, it does end up causing death, or if the early embryonic development fails, the embryo is usually spontaneously aborted, and often the woman isn't even realizing that she's pregnant if it aborts this early in development. From this point on, though, you can see in that first trimester, or even during embryonic development up to 8 weeks, you can see the majority of the different types of birth defects that can happen. So we get a variety of heart defects here. Here's the neural tube defects that can occur, such as spina bifida, some defects in upper and lower limb formation, a cleft lip or a cleft palate a little bit later. So those types of things, again, you're going to see much more likely in those early stages of development. Later stages of development, you can see there's not as likely to be as many types of birth defects. Now, some complications of pregnancy include ectopic pregnancies. This is when the implantation occurs either in the peritoneal cavity, so the oviduct never actually picked the egg up, the egg got released into the peritoneal cavity instead, and then a sperm managed to get all that way to find it. Or it could be the distal portion of the oviduct or inside the oviduct where there's just not enough room or there's not adequate nutrients available to allow the embryo to develop. Typically, an ectopic pregnancy is naturally aborted, and that would be the miscarriage. But sometimes, especially when it occurs in the oviduct, it may form a placenta and try to grow there, but there's simply not enough room and can cause extensive bleeding and is high risk to the mother. And so those pregnancies are typically terminated. Preeclampsia is insufficient placenta blood supply, so that the mother ends up becoming hypertensive and the baby ends up being starved of oxygen. The reason why some women become preeclamptic is not known, but it is very risky to both the mother and the baby. Gestational diabetes is when the mother shows insulin resistance. The cause isn't exactly known, but it might be due to placental hormones that block the effects of insulin. The babies typically come out rather chunky because since they don't have, the mother's not removing insulin, the glucose levels in the blood are high, so the baby gets all kinds of glucose and forms the fat from all that glucose. Hyperemesis gravidarum is excessive nausea and vomiting during pregnancy. I throw this one in here. not for Princess Kate of England, but for me, because this is what I went through with both of my pregnancies. My son, I was so nauseous, I ended up losing 20 pounds the first trimester. I simply could not eat anything. I even puked during labor and delivery with him. My daughter wasn't quite so bad. Parturition begins with the initiation of labor. This labor is triggered through the fetal release of adrenocorticotropic hormones such as cortisol late in pregnancy. That triggers the placenta to release estrogen, or the ovary. Actually, at this point, it's the estrogen from the placenta, not really from the ovaries. That estrogen then triggers the myometrium to start forming oxytocin receptors, so it becomes more sensitive to oxytocin levels. Also gets the myometrium smooth muscles to form gap junctions, so those smooth muscles communicate with each other better. And it antagonizes progesterone, which is all about maintaining the uterine lining and preventing the uterine contractions. As a result, then, the myometrium becomes increasingly irritable and doesn't take as much for it to contract. So you get these occasional contractions that don't have any rhythm to them. They're not predictable. Those are referred to as Braxton-Hicks contractions or false labor. The next stage then is the actual labor. This then is also triggered by the fetus. The fetus will actually release oxytocin. The oxytocin then causes the placenta to release prostaglandins. The prostaglandins cause the formation of more gap junctions and softening of the cervix. And that in turn, and as well as more contractions of the uterus, leading now to even making more prostaglandin. As a result, then, the contractions become more powerful and more frequent, so we get smooth muscle contractions with the distension of the cervix from the baby's head hitting it, also triggering the release of oxytocin, which means more contractions, which means more pushing on the cervix, which means more release of oxytocin and more contractions. And that cycle, that positive feedback, continues until finally the baby is born. One way to block preterm labor would be to use antiprostaglandin drugs, and that then would eliminate or reduce the number of contractions of the uterus. The birthing process begins with dilation stage. The dilation stage is when the cervix becomes effaced and dilated due to the infant's head being forced against it. In these first two pictures, we're looking at the cervix here. We can see it's tightly closed. In picture C here, it's considered to be about 60% effaced, and the opening here is about 1 to 2 centimeters. So it's 1 to 2 centimeters dilated. Here in D, it's 90% effaced and about 4 to 5 centimeters dilated. So we're still not ready to actually deliver the baby. It needs to get to 100% effaced and 10 centimeters dilated in order to have a vaginal delivery. The expulsion stage of delivery, it begins or starts with the crowning. That is, you see the head distending into the vulva or through the vagina, that you can actually picture or see the head coming out. At this time, the doctor may perform an episiotomy. This is an incision in the vaginal wall to help prevent tearing, because this is one big head squeezing through this little hole, and that sometimes tears the wall of the vagina. And it's better to have a cut, or the theory goes it's better to have a cut than it tearing irregularly, because you sew up a nice neat cut easier than you can sew up a tear. However, there seems to be a trend away from using episiotomies anymore. Also, during this time, the baby's head has to turn in order to fit through the pelvis. He's squeezing himself in between the pelvis at that time. Once the baby's out, the expulsion stage is over, and it's the placental stage is part of parturition, and this is the point at which you need to deliver the placenta and any fetal membranes or afterbirth. This is strong uterine contraction still to push this out, to push all this material out. It's important to get it all out because it can cause complications if left in here, including blood clots, and we don't want that. Or it can cause uterine bleeding, which of course we don't want that either. This actually I found to be the most painful part of the birthing process because the nurse was pushing on my stomach incredibly hard to get that placenta out completely. And the result of the babies being born are, here are my two kids, Keith Craig and Catherine May Hechtel, that were born. And you can see I pretty much produce one kind of baby. The only thing that can tell the difference between these two really is the amount of weight. Katie had an extra pound, so her cheeks are a little bit more chubby than Casey's. But they're cute and adorable, even today at 17 and 19 years old.